Good evening, ma'am. One second.
Hello, good evening, ma'am. You are muted, ma'am.
Sorry. So good evening, Naveen sir. How are you?
Fine, ma'am.
Welcome to the platform.
Thank you, ma'am. Thank you for the invitation.
Good evening, Dr. Laurie.
Yeah, good evening, ma'am.
And, welcome, Dr. Aishwarya.
Good evening, ma'am. Thank you.
So do you need a practice of uploading your presentation, or you know the how to do it in the Zoom? It's same like as in the.
Yes, I will just share the screen.
Yeah,
No?
please
Okay.
do it.
One second, ma'am.
Yes, and then go.
Ma'am,
Okay.
visible? Okay.
Visible. Now change the slide. Yes, it's changing. Okay. So do the same when we start.
Okay, ma'am. Yeah.
Dr. Lauren, I hope I pronounced the name proper.
Yes, ma'am, that's right.
Welcome, Dr. Yogesh sir. So we are waiting for Harshruti ma'am to join, and then we can start.
Yeah. Okay, madam. Okay. Just now I reached the hotel.
Okay, sir.
Okay. Continuing.
So-
I'm here on.
Aishwarya, any other
Yes,
student are with you?
yes, ma'am. Now no one is there with me. They will be joining.
Okay, you can share the faculty link to them so that they can participate in the discussion. Otherwise, they will be just listener.
Okay, ma'am. Yes.
Today, Baldev sir will not be there with us. He is having some social commitments. That's why. Okay, so students have started and hi.
Hi. Good evening.
Good. So we were waiting for you. So Dablina, we can start. You
Oh,
can.
Okay, ma'am. Okay, I'll be starting, and after that, I'll be handing over the session to you, ma'am. Okay, sure. Thank you. A very good evening and a warm welcome to one and all present here. I am Debolina, the designated moderator for today's session. So, Aclonet is very proud to be a part of this webinar as a digital partner, and I would like to play a short video of Clonet for all of you. Thank you so much, everyone, for your patience. Our website is www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. Besides, we have MedWiki services, which is medical Wikipedia for doctors only, that also you can read. So now, without further ado, I would like to hand over the session to Dr. Nihal Patel to start with our today's session. Over to you, ma'am.
Thank you. Thank you so much. And all to our today's section of eGurukul Pathshala PG Clinic. We have today a case discussion on CNS. And today we have with us the experts, Dr. Harshruti Ben Shah. Madam is a very good friend of mine and she is always ready whenever the PG teaching is there. She is a senior child neurologist practicing at the Rajvi Children Hospital, Rajli Child Neuro Hospital in Ahmedabad. She was with her love of teaching, she was an assistant professor in BJMC Medical College, Ahmedabad. And she is ex-professor of SBKS Medical College, Vagodia also. Her graduation in the child neurology was from Tel Aviv University of Israel, and she has the fellowship on electrophysiology from Japan. She is there with so many research papers. The list is very long, and she won the gold prize at the Taiwan Young Investigator Award in Japan and gold medal in each year of MBBS multiple research papers. So welcome, madam.
Thank you.
We also have with us Dr. Naveen Kumar Bharadwaj. Sir has not given me a long list of his achievements, but I know there is a basket. Sir has completed his fellowship in pediatric neurology, and he is now attached as an associate professor of pediatrics at AIIMS Bathinda, Punjab. Welcome, sir.
Thank you, ma'am. I am happy and privileged to be here.
Today we have on our platform the presenter, Dr. Aishwarya PV. She is from the Goa Medical College, third year, and her mentor, Dr. Loring. She is an assistant professor in the Department of Pediatrics in the Goa Medical College. Welcome, ma'am. We have our project in charge, Dr. Yogesh Sir. There are a few words from you.
So thank you very much, madam. And heartiest congratulations to Dr. Aishwarya, presenter from the Goa Medical College, and mentor Dr. Lauren. And we welcome Dr. Ashok Shah, who is my senior in the college days and PG days. And we welcome Dr. Naveen Bharadwaj from the AIIMS Bathinda. And always we are with our Dr. Nehal Madam, Dr. Atik Nikar Madam, and Dr. Vaishali Joshi Madam as our project coordinator for this e-Gurukul Pathshala. Today we will miss Dr. Valjit Prajapati sir because sir is occupying in other commitment. So let us start the program, and we will give the justice to the program. Thank you very much, madam.
Thank you, sir. So the flow is Aishwarya will start the case presentation, and at any point after history, after some of the past history, the complaints, then past history or the other history, the experts can stop her and can start discussing the case. The other students are there on the platform, and the experts can ask the questions to other students also, so that Aishwarya will feel it like a real classroom teaching and the interaction of the case. So now it's all yours, Aishwarya. You can start.
Good evening to all the esteemed mentors and the faculties and my co-PGs. I am very thankful for this presentation. So I will start the presentation.
Okay, it is full screen now. You can start.
Okay, thank you. So I am presenting the case of patient D, age 2 year 1 month old child, female child from Sanklin. Informant is mother and the history is reliable. Chief complaints of generalized floppiness noticed since 1 month of age. Delay in attaining age appropriate developmental milestones compared to other children in the family. History of present illness. Mother noticed generalized floppiness in the child from second month of age, and child was able to move all the limbs, but there was abnormal positioning of the limbs while lying down. There is also history of slipping of child when held by arms. Child is able to lift arm above shoulder, is able to reach out and hold the object, able to lift head from the bed, and she is able to turn in bed, but not able to sit from supine position. Child is also able to move the toes and knees. She's also able to move leg and can abduct the hip joint to keep the leg perpendicular to the body. She can chew and swallow food without difficulty, is having a normal cry. She is not interested in the surroundings, does not play with the mother, and does not look when called by name. She sometimes follows the mother when the mother is moving away from the child.
Excuse me. Aishwarya, excuse me. Should we go to the history again? Because the mother is always a lay person. So if we describe the history in terms of a lay person, usually they do not mention that the child is floppy. They use some other word that the child is loose, or he is not responding to the stimuli, or he is not responding to the name. So whenever we start describing the history, what would be the mother's word that is to be mentioned?
Okay.
Do you agree?
The mother described that from the second month of age, when she noticed that when she takes the baby in her arms, the baby is like very flabby, that like it's
Shall we go to the, because what was the age of a child when they presented to you?
From the second month onwards, the mother noticed.
The mother noticed, but what was the age of a child when mother brought her child to you?
Now the now the child is 2 years and 1 month.
Okay, so the history is right from the time, that is from the 2 months, but presentation is only at the 2 years, not before that. Am I right?
I have seen the child at 2 years and 1 month, ma'am.
Okay, so she came to you for the first time at 2 years.
Ma'am, I have seen the child at 2 years and 1 month, but she has already shown in another hospital.
So when you, okay, she has shown, but the history was like she had a difficulty in attaining the normal development for her age, for the age of a child. So whenever you, so whenever you mention, because when we use the word floppy, means we are using the scientific term. You understand? So the history, the presenting complaint does not mention the scientific term. It has to be in the word of a mother. So that is to be presented to start with. So now go on.
Ma'am, can I continue?
Oh yeah, please, please.
Okay. There is no history of squint, no history of drooling of saliva, no history of collection of food in the cheek, no history of deviation of angle of mouth, no history of nasal regurgitation of feeds, no history of...
Why did you ask the history of... how do you ask the history of squint? History of squint, how do you ask?
When the mother noticed any that abnormal, when the child looks at the mother, there is any abnormalities in the eyes, like
what kind of, how do you ask the parents when you want to elicit the history of squint? How do you ask the parents?
Like any abnormality in the movement of the eyeballs, or
you see that the eye is deviated on one side when the child looks at you? That should be the count. That's the question. Isn't it?
Yes.
Okay. And when we ask for the collection of the food, that is at 2 years, the best thing would be to ask whether there is a drooling of the food from the mouth when the child chews, or you can ask them whether the child chews the food or not. because that is more important. Here you are concerned with the power of a person, not and the tone.
Yes.
That's what I understand. So when you ask the tone, the next step would be, is there a loss of the power of the muscle which has a less tone?
Yes.
And if there is a loss of the power, the prediction would be child is unable to chew the food. Okay, go on.
Yes. No history of abnormal breathing pattern, no history of pressure sores or ulcers. Mother also noticed history of, there is also history of contractures in both the ankle joints. There is also history of patchy loss of hair at the pressure areas of the scalp. No history of recurrent vomiting, no history of recurrent respiratory tract infections, no history of any spinal deformities.
What is left now?
Ma'am?
One more important point which you will feel that you need to ask when the child is floating. Along with the recurrent respiratory tract infection, there is another point which we are concerned, the history of constipation, because there is a generalized hypotonia. So they usually present with a constipation. So we are always concerned that if child has a hypotonia, floppiness, or there's a change in the tone might be changing in the intestine as well. So the child will have a history of the constipation. So always ask if there is a history of constipation. So now with the presenting complaint, what is your, the first impression?
So the child presented with the generalized floppiness. And
Is it a floppiness? Is it a floppiness? The impression. Impression is what? Impression is what is your?
There is hypotonia. It's
a hypotonia. Or it's a delayed. No, it's a hypotonia.
I have not completed my present illness.
Okay.
History.
Okay.
Okay. So as there is also developmental delay, I will start with the development milestone. So in gross motor, head holding was attained by 9 months of age, rolling over by 10 months. Now the child is able to sit with support, but when made to sit, the child is able to sit with support and can momentarily sit without support, cannot crawl. DQ is 28%. Fine motor, can hold object when given in hands by 6 months of age. There's bidextrous approach by 10 months, grasp by 18 months. Now can transfer object from one hand to another, and the child does not have pincer grasp. DQ is 28%. Language, cooing at 6 months of age. He could speak monosyllables at 18 months, cannot speak bisyllables. DQ is 24%. Social smile at 6 months of age. She recognized mother at 1 year and but does not enjoy playing peekaboo, or does not respond to name, does not have stranger anxiety. DQ is 12%.
Are you complete with your history, Dr. Shwarya?
Yes. Yes, sir.
So in the chief complaint only, firstly, the ma'am has already highlighted that floppiness term is rather more of scientific term. And secondly, I would say that you have told initially that there is history of abnormal posturing. Can you elaborate on that point a bit more? So you have told specifically that there is some elaborate posturing. You go to the first slide of your history of present illness. Yeah. There was abnormal positioning of the limbs while lying down. So can you elaborate on this? What was it exactly?
So when the child was kept in supine position, the lower limbs were always in the abducted, always in abducted, that at the hip joint, and that around at the knee joint, always in the stage of extended position. So
Okay.
when
the status of upper limbs?
Upper limbs, she usually she held the arms she can lift the arm above the shoulders and all. She was touching her head, touching her face with the upper limb.
So see, this history has to be very, very specific, because abnormal positioning takes me towards some abnormal movements. And when we are taking history of abnormal movements, we should also ask that whether this positioning is same persisting in the sleep or it is changing, or there is some variability in the time to time, because I want to rule out a few specific type of abnormal movement.
Usually she prefers to lie down in this position. And it is not related to any like sleep or awake timing.
So if we remove development history from here, actually, if I would have taken this case, I have taken history of motor milestone primarily into the present illness. Rather, rest of the history I will go into the development history, because that would have given me more information. So suppose you are presenting this case, how are you going to assess this patient on neuroaxis? That how you are going to proceed that this can be the probable site of lesion. See, first chief complaint is there. It clearly seems that problem is in the central nervous system. Where is the central nervous system? If I have to localize this on micro and not on neuroaxis, how are you going to proceed further?
So here
Only do not take development history into the consideration. Take only initial 2 slides of history.
So here there is generalized floppiness is there in the child, and the child is able to lift arm above the shoulders and reach out and hold the object, and also lift head from the bed, and also can move the lower limbs also. So here the power is not affected. There is hypotonia, but power is not very weak.
Okay, good. So you feel that power is not that much involved, while weakness is or hypotonia is disproportionately more as compared to power involvement. What do we call this condition?
This is a floppy, strong.
Strong floppy child. This is okay. What else is there? What else is there? Very important point. So that means there is limb power is relatively preserved, but another thing you told specifically that this child is not able to get up to sitting.
Get up from the supine position. So the axial muscles is involved.
So axial muscles, there is more involvement as compared to
the distal muscle.
Perpendicular muscles. What another important point is there? So you were saying that child is not that alert.
So then the child is, another one is that the child is not interested in the surrounding and is not well alert and does not play with the mother. So the sensorium is also affected.
Where is this history taking me?
So this history there is UMN involvement here.
So can any one friend of yours tell me that what are the part of neuroaxis from top to the periphery? If we are analyzing neuroaxis, basically neurological axis, any one of you can say who are online. Start from top to the last part. So, Dr. Ashwari, you can...
Please participate in the discussion.
So Dr. Ashwarya has come up with very good point that this seems that problem is somewhere higher up in the brain with only two slides, and that too there is more of axial involvement than appendicular involvement, and also child is not alert. That means problem is there in the central nervous system. And where in the central nervous system? What are the part of central nervous system? We have brain and the spinal cord, and it seems more in the brain.
So
but when you are talking of problem in the brain and you are saying abnormal positioning is there, that takes me directly to the abnormal this posturing, and I want to rule out abnormal movements here, such as dystonia. So it is important for me to know that what is the specific categorization of those movements, which can take me to the diagnosis. And secondly, I would say that when you are saying 28% of development delay, 12% of development quotient, it is better to say in the range, say 25 to 35%. It cannot be that specific, because if you see WHO attainment of milestone studies, the range is very wide. So if I am a general pediatrician, for me 14 months is a normal age of starting walking. If I am a neurologist, 16 months is acceptable to me, and someone who is totally into the muscular disorder, 16 to 18 months is okay to them. So it is a wide range. It is not a pinpoint. So you can take exact percentage only when something is exactly at the 1 year of age. So here you can say something like 25 to 35%. That will give us sufficient information that is significantly delayed. So with this history, we are proceeding that this is strong floppy child and who is having global delay. So there is involvement of cognitive domain as well as motor domain. Yeah, you can proceed.
Past history. At 4 months of age, noticed uprolling of eyes with tightening of all 4 limbs. This continued for around 2 to 3 minutes, terminated on its own, and mother noticed 3 to 4 episodes per day. The child was alert and active in between the episodes. The child was admitted in the hospital, but even with the IV medication, the seizure episodes continued for 7 days. There was no history of fever. After 7 days, the episodes stopped after IV medications. Then similar episodes happened at 6 months of age. From 4 months to 6 months, there was no history of any episodes of seizure.
So can you say what is the definition of seizure?
Abnormal movements due to the electrical activity in the...
No. It is just abnormal movements, nothing else. Seizures are further classified into epileptic seizures and non-epileptic seizures. First of all, you are saying there are episodes of uprolling of eyeball with tightening of all 4 limbs. So whether it is epileptic, whether it is not epileptic, I am not clear with this information. So non-epileptic seizures in extreme of ages, they are much more commoner than epileptic seizures. So from here, it's not clear whether these are epileptic seizures or non-epileptic seizures. That too in the light when you are already saying that patient is going into the state of abnormal posturing or abnormal positioning. So can you elaborate more on these episodes?
The first episode happened at 4 months of age. At that time, the child was sleeping in the mother's lap. Then the mother noticed uprolling of eyes with tonic posturing of all the 4 limbs. And this continued for around 2 to 3 minutes. And without any medication, it terminated on its own. There was no history of fever. There was...
What was the status of sensorium? What was the level of alertness during these episodes?
During this episode, the child was not alert. The child was drowsy.
Could you ask them whether it was an uprolling or it was a negation of the eyeball, and whether there was a movement of the eyeball during this movement in the terms of...
No, it was like the staring. The mother was telling
staring.
it was staring.
It was a staring or deviation or uprolling? Uprolling is eyeball goes up, it rolls up. Deviation is deviation on one side. Staring is they are middle in between, they are looking at you. So what was an exact movement of eyeball? Because that will help you to decide whether it is an epileptic or non-epileptic.
It was uprolling was also there, and one or two episodes, the mother was telling the child was looking at her like this, like staring look was also there.
Okay. So
and there was tightening of all the 4 limbs was there, and which terminated on its own, and after that, in one day there were 3 to 4 episodes was there.
The child was taking feeds normally in between the
in between the episodes. The child was awake. The child was alert.
So the feeding pattern was normal.
The mother, first day itself, the child was taken to the hospital. Their IV fluids were started.
So when they start with the IV medication, usually the sensorium alters. So it did not alter when the patient was admitted and given the IV medication. I'm not aware. Okay. Oh, then what happened to the episodes after 6 months?
After 6 months, again similar episodes happened. That time also the child was admitted for around 5 to 6 days.
Okay. So, do you think it is an epileptic or a non-epileptic, or what are the points which help us to decide is it an epileptic seizure or a non-epileptic seizure? Any idea? Anybody else who wants to
Yeah.
speak from the audience? The other students who wants to mention in the history, do you think it is an epileptic seizure or it is a non-epileptic seizure? The other
It's an
students,
epileptic seizures.
any points by which you can differentiate these two?
It is an epileptic seizures because it came
What are the
2
points
episodes
favoring it?
that about the at 4 months of age and also at 6 months of age, the child had seizures. And
What is the cardinal points for deciding whether it is an epileptic or a non-epileptic seizure? Sir has already mentioned.
that sensorium will be
Anything else?
not associated with fever.
Fever is an, if
Unprovoked.
it is not associated with fever, it is an afebrile seizure.
And
But that's not a point which differentiates it from the epileptic or a non-epileptic seizure.
that 3 to 4 episodes per day was there, and if there is
But this can happen with any of the movement disorders also, because at 4
that
months, we suspect-
sensorium if affected.
Oh,
the
yes. Because at 4 months, I would suspect more of an oculogyric crisis. Because child is hypotonic, child had an episode of abrolic of hypo, child had only the abrolic, such as it's oculogyric. The differentiating point is a duration. Because the oculogyric crisis lasts for a long period of time. The seizures have a shorter duration. And it is associated with a minimal opistotonic posturing, which is whenever you get an opistotonic posturing in any kind of an episode, it is a non-epileptic. Okay, so go ahead, okay?
IV medications were given during the hospital stay, and the child was afterwards the child was started on anticonvulsant. The name the mother does not know, and she remember it was given 1 ml twice a day. She continued that after 6 days the child was discharged. The anticonvulsant was continued till 1 year of age, and mother stopped the medication on her own. MRI brain was done at that time during hospital stay, and she was told that some abnormality was noticed in the MRI, and EEG also was done and was told to her that it is normal. Then after 1 year of age,
It was a interictal or interictal?
It is interictal, ma'am.
It was interictally.
Sorry,
Okay,
it was
fine.
just yeah. No further episodes of seizure was there after 1 year of age. She after 6 months of age, they did not follow up after going from the discharge from the hospital.
Dr. Shora, sorry to interrupt you again. So suppose we are putting this into epileptic seizure. These episodes are happening quite frequently. So tendency to have recurrent epileptic seizures, we call them epilepsy. Epilepsy. So when you are classifying seizure, can you say where are you putting this seizure? What is the classification of seizures? So is it focal, is it generalized, or is it something else?
This is generalized seizure.
Okay. So on the basis of onset, we define seizure into focal onset or generalized onset. But when you are not sure, to the tune of 80% confidence interval, it is always better to define them as unknown onset seizures. And secondly, the drugs which we give to stop the seizures in this new era, they are known as anti-seizure drugs, ASTs. So anti-convulsant is more of obsolete term now. So when we are studying newer things, we should try to incorporate the latest terminology of International League Against Epilepsy every time with it. Okay.
Yes.
So what do you think? What will be this drug which was given 1 ml BD?
It will be levetiracetam.
Yeah.
Maybe.
Yeah, that is the drug which will have approximately that much of dose.
Yes.
Okay, continue.
Antenatal history. It was third degree. The child was born out of third degree consanguineous marriage. Maternal age of conception is 25 years. It was natural conception. She was a booked case, and the regular antenatal checkup was done in the government hospital in Sangli. No history of intake of any drugs other than iron and folic acid. No history of fever with rash. No history of decreased fetal movements. No history of polyhydramnios or oligohydramnios. No history of radiation exposure. 3 antenatal scans were taken, and it was told to her that the baby is in breech presentation. No history of any congenital anomalies noted. No history of any gestation diabetes mellitus or pregnancy-induced hypertension or hypothyroidism in the mother. Birth history. It was term vaginal delivery, birth weight 2.3 kg. The child cried at birth, and there was no history of any resuscitations. Neonatal history. The baby was kept on mother's side. Breastfeeds were given. No history of difficulty in sucking or swallowing. There was a history of hyperbilirubinemia on day 3 of life, and phototherapy was given for 2 days. The child was discharged after 5 days. There was no
Tell
history
me the
of,
maximum level of bilirubin at this point, if it is known.
so that level of bilirubin she does not remember.
Okay, so Aishwarya, you asked many of the histories, like you asked for the fetal movement. What was there in your mind during this negative history? Can you elaborate?
Yes, ma'am. If there is any element cause of hypotonia, there can be, or in hypotonia as such, there can be decreased fetal movements, intrauterine fetal movements. So that it can be that decreased fetal movements will be perceived by the mother. And
So what do you suspect? Like when you know that it is a decreased fetal movement, child is floppy. So what is your suspicion? I agree that this is a decreased fetal movement in a floppy child, but what could be the differential diagnosis in your mind when you ask this?
so spinal muscular atrophy.
Does the
and
spinal muscular
myopathy.
atrophy? Excuse me. Does the spinal muscular
No,
atrophy? So what is the meaning of spinal muscular atrophy? It's a programmed cell
This is
death post-neonatally. So
postnatally.
they usually do not have the decreased fetal movement. But there are other conditions which
Congenital
presents with the
myopathies.
myopathies. Okay. Then because you had a history of hyperbilirubinemia.
So hypothyroidism.
Okay. Nice. Congenital hypothyroidism. Anything else? Some unknown inborn errors of metabolism.
Inborn errors of metabolism.
Which one? Anybody else except Aishwarya? There are students. Anybody else who wants to speak or they want to write?
Mucopolysaccharidosis.
Polysaccharidosis not present with the hypotonia or decreased movement. There is
Aminoacidureas.
Aminoacidureas not present because they present only when there is an addition of feeds which accumulates in a sufficient quantity to present a high concentration of ammonia. That's why they present after the first week of life. That's a characteristic of IEM, where they present after first week or first month. The reason is an excessive accumulation of abnormal metabolites. Galactosemia can present levers. That's why I asked. Anyway,
Any
because
other
there is a-
condition with lot of dysmorphism?
Yes, very true.
Down syndrome.
Which one?
Metabolic.
Down
metabolic.
No, no. Even commoner than that because he has severe dysmorphism.
Menkes disease.
Menkes is abnormal excessive accumulation of copper. So once it gets accumulated, it starts presenting. So if you see logically, there are certain disorders which presents when there is abnormal excessive accumulation of metabolites or mineral. So they do not present in the neonatal period immediately before birth or immediately after. They present when there is an sufficient collection. So that's why they do not present early. But there are diseases which starts in utero, and when it is associated with severe dysmorphism associated with some MRI abnormality as well. I'm giving you the clue. Zellweger syndrome. It presents, it presents with a hypotonia, severe dysmorphism, and delay later on. Okay. So when you ask the history, it is not a stereotype. Basically, the purpose of asking you is you should have some established ideas in the mind that this is my primary diagnosis. If this is my primary diagnosis, I will ask the relevant history. That's what the Nehal madam did. That's what sir also, Bharadwaj also made. Because important thing is you should go in harmony. So when you suspect there is a hypotonia, there is a delayed motor and cognitive development. So there is something which is operating in utero. So what could be that causes? That could be congenital myopathy. Do they present? Yes, some of them presents with cognitive delay, not all. There could be some fatty acid oxidation based disorders which presents like Zellweger syndrome. Or there could be some chromosomal anomalies like Angelman syndrome, which presents with a hypotonia, floppy child, cognitive development and delay in the initial period of life. So these are the things which you should keep in the mind when you are asking the history. So always establish a primary diagnosis and then you ask the history. But the primary diagnosis, when you establish, you define, is it a motor delay? Is it a cognitive delay only? If it is a motor delay, what it is? It's a upper motor neuron type or lower motor neuron type. If you find that this is a SMA, it's a spinal muscular atrophy, it's a lower motor neuron type, then you don't expect that there could be a cognitive delay. You understand what I am telling? So when you suspect that there is a cognitive delay, means it is something about the spinal cord. So it's in the brain. So what could be the condition which hampers the growth of a brain? So that's the way the history goes. So carry on.
Immunization history, the child received vaccines according to the national immunization schedule. Last vaccination at 18 months of age. Optional vaccines not taken. Dietary history, total calorie intake is 1100. Expected is 1100 and she is getting 940 kilocalories. Deficit is 160 kilocalories. Total protein intake is 16 grams. She is getting 14 grams and deficit is 2 grams. She is having a mixed diet. Family history, she is first born to third degree consanguineous marriage. No history of infantile death in the family, no history of any neuromuscular disorder in the family, no history of epilepsy. Family tree.
So you have to ask the history of multiple emotions also along with, because when we have a cognitive delay, when we think that there are some factors which operates in utero. So if it is in a very severe condition, say if deficiency of an enzyme, it will lead to the abortion. So always, whenever there is such history, always ask the history of abortion.
Actually, I have asked about this abortions. There was no history of recurrent abortions or infant deaths in the families. So a summary, 2-year, 1-month-old female child born out of third degree consanguineous marriage, floppiness of all 4 limbs, and global development delay. There is history of seizure at 4 months and 6 months, controlled by anti-seizure drugs. No history of feeding difficulty, sensory disturbance, and focal deficits, with a good weight gain. So generalized hypotonia without weakness, with a global development delay with a seizure.
So firstly, this is definitely generalized hypotonia, but if you are saying that weakness is not there, it is not acceptable. So weakness has to be there. If a child is not able to sit, not able to hold the neck, not able to stand, not able to walk, then it is weakness only. It is not to the tune of paralysis, but paralysis is definitely there. So weakness has to
With
be
the
there.
mild weakness.
Secondly, you are saying good weight gain. We are still in the history. We do not know how much is the weight. As we are objectively saying, I do not know weight of this child. So sometimes we can commit this mistake because infant is in front of us or child is in front of us and we are saying this. So till now, I am feeling that there is no feeding problem. Child is having adequate calorie intake. So if something abnormal is coming in anthropometry, I should go back and see why this abnormality is coming. But till now, I am unaware of the weight. So this is definitely consanguineous marriage. So this is generalized hypotonia with weakness. So, but this is basically strong floppy, where axial involvement is more than the truncal involvement, and global development delay, cognitive plus motor delay is there, and it is not seizure. We do not call seizure. So when 2 unprovoked seizures are happening more than 24 hours.
With epilepsy, sir. With epilepsy.
So it is basically strong floppy in child, global development delay with generalized hypotonia with seizure. So without weakness is not acceptable term over here.
Sorry, sir. With the
And focal
So
deficit.
the diagnosis, now you change your diagnosis and tell us how would you put it?
Generalized hypotonia with mild weakness
So whenever there is a weakness, it's a motor delay. That's what we mean. So when there is a motor delay associated with hypotonia, it's a global developmental delay under investigation.
So global developmental
epilepsy.
Global
episodes are doubtful.
So what are your differentials at this point of time? 1, 2, 3. 3 only you tell.
Okay.
Anyone else who want to participate, they can write in the chat box.
Yes, please.
So generalized hypotonia with the disproportionate weakness.
This is basically global development delay. So is it cerebral palsy?
So global development delay with the epilepsy. There is no history of HIE, or there is a history, but it is not there. But
how do you differentiate?
It cannot be. It is not a CP because there is. It is not a static. The child is improved. There is improvement in the. There is a global development delay is there, but it is not a that static.
What is a definition of cerebral palsy?
It is static.
Yes. Static encephalopathy due to involvement of the due to damage to the developing brain.
So immature, it is the
developing brain, not immature. Brain is mature for the age. Always the brain is mature for the age, but it is a developing brain. So it is a static disorder because of damage to the developing brain, either antenatally or perinatally. So the 2 words are important: static encephalopathy and damage. So did you get any history of a damage to the brain? One, whatever the static encephalopathy is there, they usually improve over a period of time. If they do not improve, it is a progressive one.
Ma'am, actually, there is no history. The antenatal, perinatally, there is no history of any insult to the brain, and that postnatally the child was well and there was no history of any. There was no history. The child was well and was feeding well, and there is no history of.
There is no history
ICU
suggestive of any insult
to the-
in the perinatal period. That's what you mean to say.
There was no history, ma'am. There is no history involved. There was no history in the perinatal time, which any injury to the brain happened.
Okay.
So can you tell that how much percentage of cerebral palsy is due to causes which are happening at the time of birth, and how much percentage is the uterine life? You are getting my question?
Yes. Around
So
8.
it is primarily, if we see development of the brain, it is classically divided into 3 phases. One is age before 20th week, second is 28 to 34 week, and the rest part is after that. So before 20th week, what happens basically, there is migration of the neurons. And 20 to 34 weeks, synaptogenesis starts increasing. And after 34 weeks, size of brain starts increasing.
Differentiation.
And if you see Western literature, we are not having much of the literature. So they say most of the insult is happening before the 34 weeks of age. And that's why people are nowadays searching for the genetic causes of cerebral palsy. So if there is defect in the initial 20 weeks, there should be disorder of cortical migration. They all comes in cerebral palsy. After 20 to 32 weeks, and even these torch group of infections, they also come in that age group. So static means that child is gaining milestones, but they are at the slower speed as compared to the normal children. That is the only meaning of static encephalopathy. So if a child with cerebral palsy or if a child with development delay is worsening further, suppose he has gained some milestone and after that he is losing it. That is a regression of milestone which goes against the cerebral palsy. But it should again be differentiated from pseudo-regression. Any child who is very sick, having pneumonia episode, he will not be able to work. That is regression. That is pseudo-regression. So cerebral palsy is static encephalopathy, and in this history, there is nothing to say that this cannot be cerebral palsy till now. If we are not going into the examination, it can well fit into the diagnosis of cerebral palsy till now. So what else this case is giving us the information regarding the etiology? So we are clear with the chief complaints that this is a problem of central nervous system. Central nervous system, it seems more of cortical problem. Cortical, and there is gray matter as well as white matter involvement. So it is diffuse problem of the cortex. So this is my anatomical localization. Pathophysiologically, it seems that something has happened to the antenatal or developing brain. What is that insult? What can be the possibilities?
Yes,
So
sir, antenatally.
yeah, it seems like that only from the history. So try to
So
read
any torch infections or
yeah, it can well fit into the torch group of infection. Anything else? It can be malformation of cortical development. Anything else? You are saying questioning. It can happen that excessive jaundice. That jaundice has happened and it is causing the problem. So what is odd against Wernicke-Reyes in this case?
that tone. That tone is-
So
That-
most of them, they have relatively preserved cognitive domain while motor involvement is more, first thing. And second thing, in most of these patients, episode of abnormal posturing are quite frequent.
Sir, I can't hear.
Yeah, so I'm not audible.
They're not clear.
So I am saying, so there is some noise coming from.
Yeah, Harshit, whenever you are not speaking, please mute yourself so that wind disturbance is coming.
So I was saying that in Kernick-Tires group, usually cognitive domain is better preserved, and most of them have multiple episode of dystonia. I can see in the group, most of you are putting possibility of inborn error of metabolism. So whenever we are approaching any case, keep it as simple as possible. Systemic diseases are more common than neurological disorders. UMN causes, that means central causes, are more common than peripheral causes, and non-metabolic causes are much more commoner than metabolic causes. Congenital myopathy, somebody has put possibility of congenital myopathies. Congenital myopathy, rarely, they are primarily affecting the motor sphere. It is a case of global development delay where there is significant affection of cortex. So it is unlikely to go into that group. Congenital hypothyroidism can be, but this severe delay is not seen in congenital hypothyroidism, that they have so severe deficiency. Let's see what all is happening over. So at this point of time, I would keep possibility of first.
First,
Something happening
it is a
before-
generalized hypotonia with the comparatively less weakness, with the global development delay with epilepsy. So it's most probably affected the CNS.
Gray matter and white matter, both are involved.
White matter and gray matter. So, so my first differential will be then HIE.
HI is not something
like-
very clear diagnosis. Hypoxic
So,
damage to the brain, you can say in intrauterine life, some cortical malformation, some infection, intrauterine infection, or some other genetic cause, you can say.
or genetic or chromosomal abnormalities.
Yeah, you
Like,
continue with the rest of the part.
so, continue.
Yeah, continue.
General examination, child was awake, alert, lying in supine position on bed with both legs abducted and hands lying on the side of the head with elbows flexed. Vitals, temperature 98.6 degree Fahrenheit, pulse rate 110 beats per minute, regular, normal rhythm, and normal character. All the peripheral pulses are palpable. Respiratory rate 32 breaths per minute. BP was 98 bar 66 millimeter of mercury.
Is it normal?
It's normal for the age.
Sure. This seems to me on the higher
Yeah.
side. Recheck it once again.
Anthropometry, length 79.5 centimeter, which is -1 to -2 standard deviation. Weight 9.5 kg, -1 to -2 standard deviation. Head circumference 45 centimeter, -1 to -2 standard deviation, and left mid upper arm circumference 14 centimeter. Weight for length comes to 0 to -1 standard deviation.
So what good point is there? Head circumference is
Head
normal.
circumference is normal, and
Where is this head circumference taking me now?
so there won't be there is that torch infections we can rule out.
So few
And IEM.
extensive white matter involvement is there that we are almost taking out with this normal head circumference. And what is coming more predominant? Deep gray matter structure. Usually most of them have normal head circumference. Continue. Continue.
When you saw the patient at 2 years, 1 month, and if you are mentioning the head size of 45 centimeter, and you say that this is a normocephaly, are you sure it is a normocephaly? 45 centimeter at 2 years, 1 month. Aishwarya,
Uh,
are
ma'am,
you sure? 2 years, 1 month, 45
45.
centimeter head size. Is it normocephaly?
no,
What is a
normal.
normal head size at 1 year? 1 year of child. What is a normal head size?
50.
Okay, tell me what is a normal head size at the time of birth? Let's go like.
Ma'am, 35 centimeter.
It's not 35, it is a range,
Range.
because everybody do not have the same. So what is a range?
Any
You say
other,
that this
32
is
to 30.
any other
32
student?
to? Any
32
other
35.
student, because this is the simplest question.
32 to 36.
32 to 30,
36.
37.
36.
32 to 37 is a normal head size. Now you, how much growth of the head you expect in the first year of life?
First,
Same.
3 centimeter. First month is, ma'am, 3 centimeter. First
Oh my
month.
God.
So, that,
No. It is 2 centimeter per month for
centimeter.
3 months, and then 1 centimeter per month for 3 months.
3 months.
So total, at the age of 1 year, what is a expected head size?
50 centimeter.
45 to 46
No,
45 to 40.
no.
No, 40.
Yes, 45. So now you told me that you have seen the patient at 2 years, 1 month. So, and the head size is 45 centimeter. So, is it a normocephaly? Is it is it less than 1 centimeter?
Ma'am, your voice is not clear. It is breaking a lot.
Maybe her connections are not stable because she is traveling. Sir, you can go ahead with the discussion.
So this is
It's on the
very,
lower side.
at least blood pressure and vitals, they should never be wrong. So how much head circumference should be there, how it grows, this should be very, very clear to even MBBS.
Yes.
Growth, development, immunization. These are the bread and butter. So they should never be missed.
So this is a microcephaly. That is what I am telling you. This is a microcephaly. It is not a normocephaly.
So we are not able to hear ma'am because of some connection problem. We can go ahead in the discussion, sir.
So for head circumference, we have to see always the chart. So concept.
Sir, ma'am, sir, like from the WHO also is 40. 45 centimeter is.
I agree. It will come somewhere around -1 to
-1 to minus.
Yeah, it is -1.64 exactly if we see the chart. So for less than 5 years, we follow WHO chart. Beyond 5 years, we follow IAP chart. In IAP chart, there is no head circumference chart. So never say for a 6-year-old child that head circumference is this centile. IAP child does not come in Z score. WHO chart, they come in Z score and percentile. So less than 5 years, we are going to follow Z scores. After that, percentile only. And IAP does not have head circumference chart. So whatever has to be interpreted less than, as per less than 5-year chart. You continue.
So that head circumference is, sir, actually.
No. You leave this part. You can go again. Yeah.
-1 to -2 standard deviation only, sir.
Okay. Yeah. Okay. Continue.
Head to toe examination, head normal shape and size, anterior fontanelle closed, sutures normal, hair patchy alopecia present over the occipital area, flat forehead, hypertelorism present, epicanthal fold present, depressed nasal bridge, high arched palate not present, tongue normal, chest wall normal, no neurocutaneous markers, hands normal, feet contractures present in the ankle joint, external genitalia normal, skull and spine normal.
what is the type of these contractures? So when you are saying ankle
Dynamic.
contracture, so when I am examining a patient, I am examining that patient in particular with the intent of treatment. So if ankle contracture are there, that is going to cause delay in the walking. I have to treat that. So with that intention, how am I going to analyze that contracture over there? Is it a fixed contracture?
Dynamic.
Is it a dynamic contracture?
Dynamic
That
contracture.
comes directly to my mind. And in hypotonia, to have dynamic contracture is not usual. So dynamic contracture are more frequently seen when there is UMN lesion with
Hypertone.
hypertonia. So what was the type of, and what are the things which we do to measure these contractures? There is something known as R1 and R2. So you read what is angle R1, what is angle R2, and how do we measure it, and what is the program of rehabilitation on the basis of angle R1 and R2. You go and study that.
There is a question from chat box. Was there any plagiocephaly or brachycephaly if head holding was attained at 9 months?
There is no plagiocephaly, but
okay.
No plagiocephaly. CNS examination, child is conscious, active, not interested in surroundings. Cranial nerve.
The common cause of not interested in the surrounding. Eyes are normal.
Eyes are normal. She's looking, but she's not. Like when we call her name by name, or when we are before examining, when we when we ask when we call her by name or play with her, she's not interested in all those things.
So ears are normal because speech is not there. We are not clear of the status of ears. Is she able to listen or not?
She's there is a startle reflex when there is when she hear loud noise. But when we call by the name, she's not looking at that, but when there is sound, sometimes she looks at that.
Okay.
At the side.
Cranial nerve 1, why have you written eye contact?
Sorry, sir. It's cranial nerve 2. Sorry. Mistake. So cranial nerve 1 could not assess. Cranial nerve 2, eye contact present. She was fixing and following object.
Up to what extent?
Up to around 90 degree only.
Neonatal only she is doing that.
Sir?
That is neonatal.
Yes, sir. But she was not looking properly. To 180 degree, she was not following.
Okay.
Pupillary reflexes were normal. Both direct and indirect reflex were present. Like with cranial nerve 3, 4, and 6, extraocular movements appear to be normal. Cranial nerve 5, the child can chew food normally. No deviation of jaw on opening. And the jaw jerk actually could not assess properly, but cranial nerve 7, no facial asymmetry, no drooling of saliva. Cranial nerve 9 and 10, no regurgitation of feet, gag reflex present. Cranial nerve 12, no fasciculation of tongue. Bulk, size of both upper and lower limbs symmetrical, and no hypertrophy. Muscles are flabby on both upper and lower limbs. And
so when you mention the muscles are flabby, do you suspect a hypertrophy or wasting?
Wasting.
Or an atrophy? What do you suspect? What do you suspect?
Wasting.
Is it possible at 2 years we don't expect that they may have a nervous muscle mass if the child has not started walking? Usually they develop the wasting, or there must be the fat only. So why do you think that there could be a hypertrophy? Why did you ask the history of hypertrophy? Why did you see for the hypertrophy? In a child who has not started off, in a child who has global developmental delay, what are the points which favor that there could be an hypertrophy again?
Probably you are not able to get the madam question clearly. Madam is asking, why are you thinking of hypertrophy in a case where global development delay is?
Actually, it should be actually in global development delay there should be atrophy, and if there is some,
Mhm.
I mean, it should be atrophy, ma'am. So
Wasting.
wasting.
Atrophy. Yeah.
So many students answered.
When you ask the history, when you look for muscle wasting because of loss of pain of fat, that is, if the child not properly fed. When the child is not properly fed, there is a depletion of fat. When there is no work, it is a disuse, atrophy, or a wasting. So in both conditions are different.
So whole point is that we should always consider the case in question rather than ruling off the list of floppiness basically. That
Perfect.
these things has to be asking floppiness. Continue.
Very
So tone is decreased in both upper limbs and lower limbs, and when the child is pulled to sit, head lag is not present, but back
How to
is
do
round.
this maneuver? Can you explain?
Sir,
From where to hold the baby?
from the by the hands, sir, by the below the axilla. At the
No,
axilla.
no, pull to sit, I am asking.
Pull to sit by the hands, by the arm.
Arm or hand?
Hand, by the hands.
No. It should be from the wrist.
From this.
Prone position. So there is something known as active tone and passive tone. This is a
Yes.
part of active tone or passive tone? And
This
which
is
should be done
passive.
first?
This is passive tone.
It should be done first.
Passive tone. Passive tone. Active tone should be the child when we stretch the muscle. Active tone. So first we will do active tone, then we will.
What is the meaning of passive tone?
That is when there is
When you are not bringing the myocyte into action, basically, or muscles into the action. So,
when there is when we stretch the muscle, and that time the tone when it is felt, that is called as active tone.
yes.
When there is against the gravity, when we are assessing.
So what is this?
So this is a passive tone.
So you are not doing anything.
But we are holding the hands and.
So what is
we are
posture basically?
making-
A child is lying down. What is this? What is posture then?
So when the child is lying down, post.
No,
Sir,
it is
I
posture.
couldn't understand.
Child is lying down like this. 34 weaker is lying down something like this. 37 weaker, he is a bit closed. What is that thing?
Passive tone.
That is passive tone.
Sir.
And most of the angles, they are passive tone.
Passive
If you are
tone.
pulling something, this has to be active only.
But we are assessing that movement of the head, neck, and the back. So
It
it is
part.
against the. So that will be passive tone.
Which one? Posture, scarf sign,
Posture.
litial angles, they all are part of passive tone.
Passive
360
tone.
degree, this test is known as 360 degree flip test. This is a part of active tone. Continue.
So pull to sit, headlock not present, back rounded. Prone position can lift chin and shoulders off surface by weight on the forearm. Legs abducted at hip and extended at the knee joint. Sitting position, sit with support. Legs flabby and extended at knee and abducted at hip and back rounded. Vertical suspension, slipping through hands. No scissoring.
You tell me the procedure for this
Sir,
vertical suspension. How do we do it? And how do we do horizontal suspension or ventral suspension? And how do we do vertical suspension?
vertical suspension hold by the by the axilla, down the axilla we have to hold, and rise the child above. The support should not be to the body.
And where should be examiner? What should be the position of examiner?
The examiner should be standing and should be behind that child.
Yes, very good. Examiner should always be behind the child. Okay.
Ventral suspension over the hands, which the abdomen of the baby should be placed, and lift the baby.
Okay, continue.
Power could not be assessed in this baby, in this child, but the child can move all the joints against the gravity, more than 3/5.
How was the movement of ankle happening if there are contracture?
But the child, there was, it was, but the child can move that at the ankle joint. That I have checked. The child was able to move.
Okay.
So reflexes, bilateral biceps and triceps were 2+, and knee and ankle jerk were 3+. Plantar was extensor, and primitive reflexes were absent.
Which is abnormal?
Sir, knee and ankle jerk. And plantar.
Okay.
Respiratory system, there were no retractions, normal pattern of breathing, air entry bilaterally equal, no adventitious sounds were heard. Cardiovascular system, S1 is to heard normally, no murmur, and perabdomen was not distended, and umbilicus central, no dilated veins or scars, no tenderness, no palpable mass, and normal bowel sounds. Summary. 2-year, 1-month-old female child with generalized hypotonia with global development delay, with epilepsy and dysmorphic features, thriving well child with a decreased tone and not significantly reduced power, and normal or exaggerated reflexes, without cranial nerve abnormalities and no focal deficits, with no associated malformations in other systems.
Diagnosis?
Aishwarya, how can you write it? No, but it's, see, this has been mentioning that there is a no significantly reduced power. So how do you assess the power in 2-year-old child who has not learned to sit?
Ma'am, actually, if we want to differentiate between that UMN and LMN lesions,
Yes,
so,
it is not a question. Power.
so
Power.
mostly in the LMN involvement, there will be very much decreased in power. So the
And in
child,
UMN, there is a preservation of power. You
UMN,
think so? No. Power has nothing to do with the lesion. Power is always low when the lesions are involved because it's a motor power. So it is a motor system. So when there is a delayed development, how can we say that there is a normal power?
in this child, the child can move all the limbs.
But
and
was it
against
against the
gravity.
resistance? Child could move the limb, but was it
we
against?
I couldn't examine, ma'am, that
So
power
that's
against
why
the
you cannot
resistance.
mention that
So
this
we
is
can't
a
be
normal
sure
power.
that.
Yeah, because child has not achieved the motor milestone for the age. He has still not reached to the age, and simultaneously, the power has not been examined in a proper manner of a grade 4 or a 5 by putting both hands against resistance. If child is able to move the head above the head in a lying posture, does not mean that this is a normal power, because that signifies only grade 2 plus or grade 3 only. So this is not a normal power. That's what I want to say. That's what we were discussing till now, that this is a global developmental delay, and this, when there is a delay, the power cannot be normal.
Ma'am, I was implying that the power is not like 0 or +1.
No,
so
anything
that-
which is less than 4 or 5 is always low. It is not 0 or 1. See, when you speak about the power, means you are describing in a degree, grade 1, 2, 3, 4, and 5. If anything less than grade 4 is always low, it does not mean that it has to be 0 or a 1. It is not like, you cannot define that this is a low power and it is a normal power. So when you mention the summary, you should be very specific. That's what we mean. You should be very specific in a way. What was the condition, like cognition, and I mean defined in 2 parts: motor and cognitive. Developmental delay, progressive, non-progressive. When it is non-progressive, again motor, cognitive. Motor, either it is a focal or it is a generalized. Cognitive, which area of the cognition is involved. That's the way we always discuss. Say, for example, if I want to describe a cerebral palsy, I would write that this is a static encephalopathy with visual field defect with severe dyslexia or a slow learner. So it implies all portions which are associated with cerebral palsy. Similarly, this is a child with a developmental delay and it is a cognitive delay. So it does not mention the power. The first thing is, you do not have to mention the power when you are speaking the summary or anything. What you have to mention is the condition, like what we asked in the history. It has to be in patient stuff. This has to be a condition. Now you tell us, what is your diagnosis?
Ma'am, it is a CNS involvement.
Diagnosis, final
Diagnosis.
diagnosis, one line only.
Like chromosomal abnormality.
No. Physiological, pathophysiological diagnosis. It will be global development delay
Global, okay.
with hypotonia, with or
generalized
quadriparesis with epilepsy.
Generalized hypotonia with global development delay with epilepsy. Most
Secondary
probably secondary to
with dysmorphism also.
with dysmorphic features, secondary to chromosomal abnormalities, like
Any specific diagnosis in this patient with the dysmorphism she is having?
specific that dysmorphism, that specific features are not there for. Specific diagnosis is not there for that dysmorphism.
But I somehow feel that there are few autistic features also. So child is some abnormal movement. She is having poor eye-to-eye contact. She's not interested in surrounding. You are saying despite having good vision and hearing. So it seems that few autistic features are there, and they are very common in this group of patient. Even in a patient of cerebral palsy, seeing these autistic features is not uncommon. So in most of the developmental, they are there, and I still feel that few of the autistic features are there.
Prader will tell me.
Prader-Willi should be, these trisomy syndrome should be high on the list with this dysmorphism. Now, how are you going to move with diagnosis and rehabilitation of this child? Two very important aspects. And second aspect is rather more important, rehabilitation. So what are you going to do with this child? You have to reach some diagnosis.
The diagnosis can be, sir, actually my diagnosis.
How will you proceed to reach the diagnosis?
There is global developmental delay in this child, and generalized hypotonia and epilepsy is also there. So the CNS is involved, and it can be due to like a chromosomal abnormality like Prader-Willi syndrome or cerebral malformations or congenital myotonic dystrophy, inborn errors of metabolism.
Okay.
So
What are the point against and points in favor of cortical malformations? What is point against?
that the child visually and that hearing is preserved.
Cerebellar
And
malformation, usually this level of dysmorphism is not usual. Most of cerebral malformation, there is involvement of gray and white matter. So most of these kids, they are hypertonic by the age of 2 years rather than hypotonic. In infancy, they can even be hypotonic. This is what my experience, ma'am, can better say. So congenital myotonic dystrophy, there is usually mother involvement. So you should take history.
muscle involvement will be there, and
They have, most of the time, they have open mouth, and cognitive domain involvement is there, but not this significant. Inborn error of metabolism should progress somehow. Either epilepsy should worsen, either the development milestone, the way this baby is achieving, this should not be there, and same is true for the paroxysmal disorder. And spinomuscular dystrophy is totally out. It should not be there in the differential diagnosis. If brain is involved, SMA out. They are very alert, rather hyper alert child, very good, very intelligent kids. Ma'am, you can please comment. Ma'am, you are muted. Please unmute.
Sorry, sir. Okay. So when the pyramidal brake is involved, you find an alteration of the tone. And when you find it is a cortical involvement, you usually do not find they are hypotonic. So he is absolutely right. But sometimes we find a normal tone in most of the patients. And if it continues without rehabilitation, you find the contracture. Otherwise, you do not develop a contracture for a long period of time. So when you mention about the contracture, the developmental malformation usually is ruled out. Secondly, the CNS involvement is usually ruled out because contractures present only if there is a particular posturing and there is involvement of a particular tract. So you find a contracture with a neuropathies, but not in a patient with a global developmental delay. Very less likely we have seen over a period of time. So when you mention about the contracture, you should be very specific what you are thinking. Very less likely, except the neuropathies, we do not develop contracture in patients with cerebral palsy with developmental malformation. They don't develop the contracture so early. So that has to be kept in the mind.
Ma'am, that can be due to that intrauterine. The mother was telling from the birth the child was having. So maybe, and the child was also that breech presentation.
Not the or a love fruit deformity. Do you mean so? Because it is present only in the toe and ankle. Do you mean it is a clubfoot deformity or a contracture? Because they may present, the clubfoot could be present at the time of birth, and it is not a contracture. This can happen in a hypotonic child when there is a chromosomal anomaly. So what was it?
What is there on MRI? You told that there was some abnormality on MRI. Not a part of discussion. I am just eager to.
Sir, MRI actually showing some HIE features.
Can you project that MRI here?
Sir,
MRI pictures you are having in the
no,
presentation?
no, sir.
Okay, no. But why it is not HI? So you should always
can-
try to lay some hypothesis. Most of the time you will be right, but if you are wrong and your process of reaching the diagnosis is right, no issues. Everybody can be wrong. But still, even after so much of discussion, I still feel that this cannot be something like HI.
That now that diagnosis I have made previously. So now after discussion, I feel that it's HIE.
No, I still do not feel this is HI. I still feel it is a syndromic problem probably.
Sir, HIE can be there.
No, it is very unlikely to have presentation
No,
like
no,
that.
we agree that it is an HI. But what kind of the trait is likely to be involved in a patient with HI? So which are the areas which am I audible?
Yes, ma'am.
Yeah. So Aishwarya, can you define that what are the traits which what are the areas of the brain which gets involved with a mild HI, with a moderate or a severe HI? What are the areas of the brain which gets involved? A simple question.
Ma'am, that there can be like a periventricular locomalacia.
I agree, the periventricular. So it involves which trait?
That is white matter, bilateral white matter.
So these are traits. Traits is a white matter. So which trait?
Motor cortex.
So if the motor cortex is involved, what will be the clinical presentation?
That is a spastic, ma'am, spastic diplegia.
So here what you are describing is?
Here it is hypotonia. So
hypotonia. So does it favor? It is an HI?
So
and if it is a female, and if it is only motor trait, then does it involve the cognitive involvement? Do they develop autistic features? Right from beginning, without any history?
If there is any selective neuronal necrosis or anything like that, it can involve that there can be seizures and
if the seizures are uncontrolled, then there could be an autism. So when you describe that this is an HI, if you know that these are the traits involved, does it fit with your clinical diagnosis? Does it fit with the development of a contracture at the knee and toe? Do they develop a contracture right from beginning? And is it really a contracture or something else? Or what are the conditions which? Yes.
Maybe the child was not moving that angle joint properly, so that contraction might have developed afterwards also.
But you said that the mother was telling that these are the stiff ankles,
it
right?
Was mild, it was there, but now I feel contracture is there. It's contracture only.
What are the conditions which mimics like
maybe there's like arthrogryposis like that, like intrauterine or
that's what I told you. Arthrogryposis can be present, but in which condition arthrogryposis present with HI, or you think that there are
arthrogryposis and like congenital myopathies and like or intrauterine if there is decreased movement.
So you think that there are two different etiologies? There was an arthrogryposis with superimposed changes of HI. Do you think so? So rather than we jump onto the,
it is not congenital myopathy and all, because there is that reflexes are also exaggerated, and power is also not significant. Power is like more than 3/5 is there.
Okay. So how would you conclude the case? We are not supposed to establish a definitive diagnosis, but how would you conclude? Like, how will you go ahead? That's what we want from the residents? Like, how would you examine them clinically? How will you approach them to the clinical diagnosis? And how will you proceed for the sequence of investigation? This is what we want.
So here there is CNS involvement. So that MRI brain is to be taken, and to know any to rule out any cerebral malformations.
But you said there is a
Right.
hypotonia. So did you think of doing something else?
Yes.
What for the hypotonia before MRI?
For the creatinine kinase.
Yes.
So
CPK.
CPK. So
But is CPK justifiable with this child? And what are the
CPK
justifying
is
points
not
except
justified.
hypotonia? Why?
If we are suspecting any UMN lesions, then CPK will be normal. So we are here. We have ruled out all the.
What are the points
lesions
which
and muscle involvement.
What are the points which does not justify clinical? You have examined the child. You know the clinical. The points.
So,
that this
ma'am, there is.
Yeah.
So here there is. We are excluding that element lesions because that there is no wasting. That power is more than 3/5, and reflexes are 2+ or it is exaggerated. And
was there
is
a
also
clonus
CNS
present?
involvement.
Was there a clonus present?
There is no clonus. There is no fasciculations.
Okay, fine.
And
Yes,
there is
okay.
also.
Aishwarya, if there are slides, can you stop sharing?
Ma'am, slides. Okay.
There are no more slides to
Okay, ma'am.
stop.
So any other investigation you will go for before you plan for the MRI? One was CPK, not justified. Anything else which comes to your mind that this suggests that there is a hypotonia, there is a low
That
power?
EMG,
See, when the CPK is not
that is
justified.
CPK and EMG is also not justified, ma'am.
No, I'm asking you the blood investigation.
So the blood investigations.
Which are the other conditions which can
ma'am,
mimic like a cerebral palsy, and then you will think that, yes, I have to go for this. What are those conditions where you will think for some blood investigations?
Ma'am, this hypothyroidism and hypothyroidism
Yes.
we have to rule out.
Okay.
For thyroid function test, we have to free T4 and TSH we have to do.
Okay.
Then other investigations.
Which one? Common, microcephaly, autism, developmental
Then,
delay, the reflexes are
torch
good.
infections.
Torch?
Torch.
No, no torch. Which is not commonly seen
all
in
the
art.
inborn errors of metabolism we have to exclude.
Which one?
So
how do you exclude?
So by the test ammonia we have to do, and
okay. If ammonia is normal, then
and
if ammonia is okay, how do you do
to rule out the acidosis?
The ammonia,
ammonia lactate
for the. No, just I'm asking that you are a resident and you want to send an ammonia. When you will send and when you will find that this is positive. I mean, what are the values which will give you that this is a high ammonia? And when you will send, which is the ideal condition to send an ammonia level?
Any other resident who have sent the ammonia knowing this?
Ideal,
How should sample be taken? Where should it
yes,
be? At what time
yes.
it should be? Question is specifically that.
So
Sir,
Rahul can tell.
sir, we will take, sir, actually, I didn't get the question.
So suppose there is a patient for whom you want to do serum ammonia level.
Yes.
So when you are planning to collect that sample, how should it be collected? What should be the vial and how should it be transported?
So that pre-chilled EDTA bulb will take, or and around 2 ml bulb, 2 ml blood is put in that bulb, and immediately we have to send for the investigation.
Any specific temperature?
Sir, 2 to 8. On the ice pack, we are usually sending, sir.
So ideally it should be freeze sample.
Freeze,
And
of
it
course.
should be, if kids are small, there should be gap of at least 2 to 4 hours. So neonate, we say 2 hours are sufficient. And there are totally separate cutoff for the neonate, and for the bigger children, cutoffs are totally different. So it should be pre-feed rather than immediately post-feed. So just before the next feed and freeze sample, but that is not.
It is 2 hours NBM.
But it is most of the time not practical to do that way, especially in the setup we work in. I don't know the rest of the setups.
So we usually keep the patient nil by mouth for 2 hours before we take the blood. It is not to be squeezed, to be sent immediately, to be sent on the ice pack, and twice the normal values are significant to establish that this is a patient with hyperammonemia. Any other blood investigation you will think for this child having a microcephaly, autism, and developmental delay, which mimics like a cerebral palsy? Any other condition where you will think of taking some blood, common, which you should have diagnosed when the child was presenting with the first episode of a seizure, so that you could have survived the child, you could have salvaged the brain, you could have given a good development?
Thoughts, rubella infection, congenital.
Congenital?
Congenital
Phenylalanine
rubella.
level you should, yes, phenylalanine level is to be checked. They present in the almost similar way. Second is a homocysteine you have to check.
Homocysteine.
So these are the blood investigation before you jump for the MRI. Now you will ask for the MRI. Which are the other things which you will ask? You will see the report, or you will ask something else to be seen in a patient with hypotonia, developmental delay, with autism, to the radiologist for the MRI. You will send simply the MRI, or you will ask something else to be done on MRI, which is common. I mean,
Spectroscopy.
moment you,
MR
sorry?
spectroscopy.
What you will see on the spectroscopy? Why you are asking the spectroscopy? What is there in your mind which you will ask them to see? Very simple. I mean, it's a simple question to be seen always. Which you will. Creatine peak, you always have to. You always have to see the creatine peak, because that is absent in a patient with hypotonia, with autism, with developmental delay. The patient is having a creatine deficiency. And if you supplement them with a creatine powder, the child will improve. So these are the important things which you can diagnose them, and you can treat them easily. Any other therapeutic tests you will do for this child? Because he had a history of abnormal movement, had a hypotonia, developmental delay. Any therapeutic trial you will give, because he had an abnormal posturing of the body. We suspect that this is thinking that this is a movement disorder. Then what kind of therapeutic test you will do for this child? Any other medicine you would like to give for this child when you have not found anything on MRI? Say, for example, patient's MRI is normal, perinatal history is normal, child is having this kind of presentation. any therapeutic condition, test or a treatment you will give for the establishment of a diagnosis. Because sir told you that this is a dystonia. We were thinking that this is an intermittent episodes of dystonia. I'm giving you the clue. So
Uh,
thiamine usually presents with episodes of the epilepsy or status epilepticus, and they usually have initial normal development. It is not only the thiamine, but it is a thiamine biotin responsive basal
vitamin
disease.
B12 deficiency.
Okay, so you will,
Vitamin B12.
okay, but your homocysteine is normal then.
Uh,
See, repeated episodes of dystonia with the abnormal posturing occurring in between, you can give a dopamine, low dose of dopamine, and see the result after 48 hours. Sometimes patients with dopa responsive dystonia with a different mutation can present with a developmental delay. Otherwise, they are normal by development, but they present with a dystonia. So these are the things to be kept in the mind, but it is only for the differential diagnosis. What you need to learn is basics. Basics is what is a normal head size, what is a normal tone, what is a normal power, how do you assess the power, how do you assess the contracture, is it really a contracture or it is a deformity? So the clinical diagnosis is must before, or the clinical examination has to be very precise and correct before we jump for the investigation, so that you can narrow down the investigations. So always detailed clinical history and detailed clinical examination before you proceed for the definitive investigation or a treatment.
yes.
So, any final comments from both the experts? Ma'am has already summarized many of the things.
Yeah,
Naveen?
Aishwarya has nicely taken this case. So the only my viewpoint is that we should always try to think on every point, whatever is happening. Try to think systematically. If this problem, where is the problem, how it is proceeding, what is the, so the classical, I say it, Dr. Amdekar style. So we should always proceed in that fashion. I am listening sir for almost last 10 years, and every time that is the only relevant thing probably which sir has told many years ago, and sir has published in his book also. What is the problem, where is the problem, what is the pathophysiological mechanism, what is the cause of problem, and what is the malfunction it is causing. So these 5 points, if we are thinking on them time and again, so we will be reaching the diagnosis. We can be wrong in our hypothesis, no issues. Many people are wrong, but at least we should try to lay down some hypothesis. Nice job.
So thank you so much. Both the experts, Naveen sir and Harshruti ma'am, they are always here to guide the students, and ma'am is always like helping the students also. It's take a courage to face so many people on the screen. So Aishwarya, for
Yes.
that, congratulations to you.
Yes.
Presented a very nice
Very good.
case. And congratulations to the mentor also. So Lauren ma'am, she is here and fight for whole of the discussion. Now, and so ma'am, it's a very nice mentorship, and she has tried to answer many of the questions.
Difficult questions.
Yes,
Very nice.
So the beauty of this.
Was really nice. A lot of learning points for us faculty too. Thank you so much.
Thank you. Nice. It was very nice case. Really interesting.
And we
Okay.
always learn when we hear any of the case. Whenever I am attending, I always learn something. With here, Aarti Katkar madam is also there. She is also one of the coordinator for this session. Ma'am, any comment from you? I think, okay, so let's go ahead.
I just joined in, so I had to go for a meeting. We are having a nursing strike for last 5 days. So I
Oh my God.
listened in the early part and the last bit. So I think I am not the right person to comment because I didn't hear completely. But I will thank both the experts and also the student who has presented today. So I hand over you, Nehal.
Thank you, ma'am. One request to all the students who have joined. So throughout today, many of the students have given their inputs in the notes. And even Naveen sir has given them all the answers also in typing. But we can have still a live discussion so students can answer by themselves. So for the next session, we can do this. For the Saturday, we are planning a journal club. All of you are invited. Those who want to have participation and active discussion can text me and I can send the. So thank you so much. Aishwarya, Naveen sir, both Harshruti madam, both the experts.
Thank
Lauren,
you.
and
Thank
the
you.
Goa.
Thank you,
Thank you.
ma'am. Thank you.
Thank you. Thank you, Aishwarya.
Thank you, ma'am.
Nice
for the- all
presentation.
the things.
Bye.
Good
Bye.
job.
Thank you, ma'am, for all the.
Yeah, nice. Bye.
Thank you, sir.
Bye. Thank you.
We can thank you, Clarinet, for providing this platform, and we can close the session now.
Okay, thank you.
Thank you so much, everyone. We're closing the room. Good night.